This is Alyssa Leone, and I'll be presenting my CSD 408 Adult Practicum case study on RF. So here's some background info on RF. She is an 86-year-old female resident at Grace Plaza Nursing and Rehabilitation Center in Great Neck, New York. She's a monolingual English speaker. She is widowed with 2 sons, lives in Long Island, New York, was previously very active in her community prior to admission, and was admitted from an acute care hospital to Grace Plaza on March 16, 2018. Medical history. So RF has a history of hospitalization. She had a prior CVA in September 2017, which she made a full recovery from. The 2018 hospitalization that led to her admission at Grace Plaza was a left middle cerebral artery stroke. According to Stein et al., if the infarct is in the dominant middle cerebral artery distribution, there is damage to the language network, including Broca's area, Wernicke's area, the angular gyrus, and the arcuate fasciculus. A CT scan indicated that there was a large infarct with several components involving the temporal region, the temporal parietal region, and the high parietal region, with some appearing acute or subacute and some appearing subacute chronic. Secondary to her stroke, the patient presented with a new onset of severe expressive and receptive aphasia, consistent with having global aphasia and dysphagia. RF also presented with the hallmarks of global aphasia: reduced fluency, severely impaired comprehension, and an inability to repeat, read, or write. According to Wattila et al., this aphasia in adults is most often secondary to stroke in the language-dominant cerebral hemisphere. That is, they have suffered damage to the parasylvian cortex, which includes both Broca's and Wernicke's areas. Global aphasics are typically more impaired in all tasks. Upon admission, it was determined that RF was at risk for both aspiration and social isolation. The Western Aphasia Battery was administered to RF and revealed severe deficits in both expressive and receptive communication, especially in the areas of naming, word finding, auditory recognition, and following directions. Her speech consists of neologisms, both semantic and phonemic paraphasias, perseverations, and occasional logorrhea. This logorrhea or incessant talking made her unsafe for regular consistency foods because she would talk uncontrollably during mealtime and have reduced attention to task. Due to these diagnostic results, it was determined that the patient required skilled SLP services for cognition and communication to analyze her communication abilities and improve language function in order to enhance her quality of life by improving her ability to communicate her basic wants and needs, communicate complex thoughts, ideas, opinions, and/or feelings, and participate in meaningful interactions with others. So here are the ICD-10 codes, G codes for current status at time of initial therapy, and the functional communication measures. So for aphasia, following a cerebral infarction, the G code for spoken language comprehension is G9159, and the FCM is 1, which indicates the individual is alert but unable to follow simple directions or respond to yes or no questions even with cues. For spoken language expression, the G code is G9162, and the FCM is 2, which indicates the individual attempts to speak, although few attempts are accurate or appropriate. The communication partner must assume responsibility for structuring the communication exchange, and with consistent and maximal cueing, the individual can only occasionally produce automatic and/or imitative words and phrases that are rarely meaningful in context. So, as you can probably tell by this information, the patient has some pretty severe communication impairments. When it comes to dysphagia following a cerebral infarction, the G code is G8996 and the FCM is 4, indicating that swallowing is safe with moderate cues to use compensatory strategies, or the individual has moderate diet restrictions. Plan of therapy. RF is currently being seen in speech-language therapy 5 times a week for a period of 12 weeks in 30-minute sessions. She also goes to physical therapy and occupational therapy every day. This approach is being used because stroke patients who receive inpatient rehab provided by a coordinated, multidisciplinary team are more likely to recover the ability to perform activities of daily living and are more likely to return to their community. So these are the long-term goals for RF as written in Rehab Optima, which is the software program that Grace Plaza uses. So the first long-term goal is the patient will increase verbal expression skills to minimum or close supervision in order to communicate basic wants and needs, communicate complex thoughts, ideas, opinions, and/or feelings, and participate in meaningful interactions, activities of choice, improve expressive communication, and improve functional communication skills. Long-term goal 2 is the patient will increase auditory comprehension skills to minimum or close supervision in order to communicate basic wants or needs, communicate complex thoughts, ideas, opinions, and/or feelings, participate in meaningful interactions, follow directions for activities and activities of daily living, and allow for increased socialization, improve receptive communication skills, and improve functional communication skills. The third and final goal is the patient will safely and efficiently swallow regular textures 90% of the time using compensatory strategies and/or maneuvers as trained as evidenced by minimal to absent signs or symptoms of oral or pharyngeal dysphagia. So for RF short-term goals, we have the patient will produce automatic speech with 60% of attempts and 100% verbal, visual, and semantic cues. Patient will follow one-step verbal commands with 50% accuracy and 100% verbal, visual, and tactile cues. And patient will repeat core functional words with 75% accuracy and 75% verbal, visual, and tactile cues. And these are all in order to increase her ability to communicate her basic wants or needs, communicate in meaningful interactions, improve expressive and functional communication, and increase socialization. And here are the rest of her short-term goals. So we have patient will discriminate body parts with 60% accuracy and 100% verbal, visual, and tactile cues. And patient will correctly name pictures with 60% of attempts and 100% verbal, visual, and semantic cues. And again, this is in order to increase her ability to communicate basic wants and needs, participate in meaningful interactions, improve expressive communication, and functional communication skills. And for the last two short-term goals, we have her dysphagia goals. So a patient will present with functional mastication skills in order to safely consume mechanical soft textures in 8 out of 10 therapeutic attempts. And the patient will increase her ability to clear the oral cavity of mechanical soft to mild in order to increase her safe oral intake. So, although I did not make these goals, I do agree with them because I think they address the skills that were determined to be most impaired during the evaluation process. I also think that they're appropriate because the client was extremely motivated to work in therapy due to the frustrations that her aphasia caused her. And I think that these goals reflect functional skills and strategies that she can use during activities in her daily life. Dysphagia therapy and progress. So RF's swallowing goals were actually met in about 2 weeks. She was administered to the skilled nursing facility on puree because of compulsive talking during eating, for which she was taught compensatory strategies in therapy. As a result of Mac's clinician cueing and familiarization with the facility, she was able to decrease her talking and increase mealtime safety. After a couple weeks, she was upgraded from puree to mechanical soft, and her mastication skills and ability to clear the oral cavity of food were determined to be within functional limits. Receptive language was the area in which RF presented with the most deficits. Therapy was initiated with max cues for every goal and still remains set at max cues. This includes showing the patient visual stimuli, writing words down for her, and even clinician modeling of the target. At the start of therapy, the resident had less than 25% accuracy in all goal areas. Her biggest improvement in receptive language was seen in repetition of core functional words. So these include words like hello, goodbye, nurse or doctor, hungry, pain, help, etc. So at the end of our therapy time together, she was about 25% accuracy on that task. For following commands and discrimination of body parts, she was still at less than 25% accuracy, and there were some sessions where she was not stimulable for those tasks at all. Expressive language therapy still remains set at maximum cues as well. During automatic speech tasks like days of the week, months of the year, and numbers, the client would be presented with written words or pictures representing the task and would be asked to recite them along with the clinician. During this task, RF would very often perseverate on numbers such as 406 and 502. She would say those very often, almost every session, and would also frequently use phonemic and semantic paraphasias. On this task, she achieved less than 25% accuracy over our therapy time together. Naming was the task in which RF made the most improvement during therapy, with 25% accuracy over time. Some types of confrontation naming cues that can be provided are phonemically based cues, so a verbal cue consisting of the first consonant or first consonant plus a vowel in the target word. A graphemically based cue, so a letter or a first grapheme of target word, but in our case we would actually use the entire word and would have the word written on the back of the card like the pictures here show. Both phonemic and graphemic cues, which is the method that we use the most, which I'll discuss in a second. Sentence completion cues and word or sentence repetition cues. So like I said, we mostly used both phonemic and graphemic cues. RF would be provided with a picture cue card that had the name written on the back of it. So she would be instructed to look at the picture and attempt to name it, but she knew that if she couldn't, she could look at the back of the card and see the entire word written, which would often help her to express the target. If not, she would be provided with the name of the object verbally. So a combination of looking at the picture, the word, and the phonemic cues from the clinician often help her to achieve the target. Prognosis and outlook. Prior to therapy, it was stated that RF demonstrates good rehab potential as evidenced by a recent onset and a high prior level of function. A 2010 study by Samania et al. Showed that the recovery of global aphasia after a stroke is not limited to just the first years following onset, but actually can extend for even more than 1 decade. This unique long-term follow-up study showed that the time span for recovery of language functions in global aphasia after a stroke may be much longer than previously documented. As shown thus far, the resident has made slight progress in some areas such as naming of everyday objects, but she still requires maximal cueing. Since she is so highly motivated, if provided with consistent follow-up and word-finding strategies and close supervision from family members and staff, it is predicted that RF still has good rehab potential. Here are the references I used in this presentation. Thank you for watching.